So in the National Opioid Use Guidelines, the Cluster 2 is the second phase of information where they're just summarizing how is it that we monitor and start this trial. So the principles always hold true. You want to start low dose, you want to go slow and titrating up, and looking at some optimal dose. And optimal dose doesn't mean perfect. It doesn't mean that the pain's completely gone, but that the goals of the functional outcomes that the patient and you have agreed on is met or is actually getting towards, and that we're achieving some stability in the symptoms. And sometimes when it's during crisis pain, it's just simply stability of mood that may be the major outcome, at least for the time being, to achieve. So during this time, of course, documenting the progress is key, and that's why those goal setting up front, even before the trial gets started, is so key. I made reference in previous slides on how to establish some goals up front so that we know where to go with this therapy. And just to reemphasize, this slide is making use of the other arms of pain management, which isn't just dealing with the numeric rating score or use of a medication. We need to see a patient move and function better, need to build their confidence in going back to certain activities that won't increase harm. So physical therapies, psychological therapies, complementary therapies have a big role as well. And obviously the other types of medications have their parallel use. But finally, just wanted to emphasize that in pain management in particular, self-management strategies to help overcome fears and to actually use even their medications better are so key. And there's a number of resources that other presentations are going to be addressing. So here I wanted to just summarize the typical analgesic toolbox as they refer to it. So there's the general non-opioid group and then the opioids that are available in BC. So here in BC, we are familiar with the Butrans patch or the buprenorphine patch. There's also the fentanyl patch, but those are not usually used in patients who have not been exposed to opioids at all. The others are codeine, hydromorphone, morphine, oxycodone, and tramadol I would even put in here as a mu agonist. So in this slide, I just wanted to summarize, there's a number of factors that impact the way we choose which opioids to start with. If someone hasn't been exposed to opioids at all, obviously maximizing non-opioid management strategy is the way to go. But if we're getting to the time where we're making a decision to start an opioid, then many of them are appropriate. Most of the time as clinicians, we start off with a short trial of the short-acting ones to see if there's even any effect, and also if there's any major side effects that will limit the way you can increase your doses. The other factors, of course, includes cost, coverage, how compliant a patient is of short duration and frequency of dosing versus single-day dosing, and then of course what their past experience was in the past with any medications in general. And then lastly, there are some practical points like, are they able to take the medications orally, or we have to start considering patch forms, what's their digestive system and their liver system in clearance of these medications. So some of these will play into our decision. These next two slides are pretty busy. They just summarize some guiding principles as to the starting dosages on the various opioids available to us in BC. So codeine, tramadol, morphine are located on this page. And without going to all the details here, really at the very far right of the slide is some suggested optimal maximum dosages. Like it is with the National Opioid Use Guidelines document, they do feel that the oral equivalent of morphine of 200 milligrams per day is what they call a watchful dose. So you can see here that these are under or at about the equivalent of that dose to be the guided maximum. For non-cancer pain, it is accepted in the community that beyond that doesn't quite make sense, the diagnosis may be wrong, or that there are other factors involved in these higher doses, and we really need to review with vigilance, especially at that time. The second slide is also highlighting the medications, particularly oxycodone and hydromorphone. You'll notice on these slides I have not put on buprenorphine or fentanyl patches, but I will address the equivalent doses in the next slide. This slide generally summarizes the accepted equivalences that has been understood in the clinician community. They are not hard and fast rules, but they are just general guidelines, and it really changes depending on how much and how long a patient's been exposed to opioids. Also, elderly age versus young ages is very different. The renal and liver function totally changes these equivalences. Methadone in particular is a very variable medication to try to transition to, because that really depends on how long you've been taking this medication.